Hello, my name is Brittany Jones. Our Leadership Anne Arundel team is happy to partner with Anne Arundel County to fight the opioid epidemic. We come from different backgrounds, but we share a common interest in doing our part to help solve this problem.
And I'm Latoya Congolo, a licensed clinical social worker and addictions therapist in Leadership Anne Arundel. This video engages the medical community to make smart decisions to avoid creating new users. Please enjoy Not My Child, a prescriber's perspective.
You know, I'm not a clinician, I'm not a doctor or anything. I'm just a broken-hearted mom. And so I think that's how they relate to me, is that you know what, I didn't think, that my son would ever use heroin. I never said not my child, but I think that we need to think it could be anybody's child. I absolutely think that they are in denial of how a parent would be. I know that when Jake was given his prescription, it was given to his dad and I, and we gave him his medicine as prescribed. And so, I don't think that his dad and I had any intention or thought that this could happen. And never once did the doctor say, you know what, he's going to be on this for 3 or 4 months. This could be a potential problem. And it was a problem for Jake. And then having 2 years sober and being re-prescribed pain medicine, when he told the doctor he was in recovery, when I was standing right there, the doctor said, son, the little bit of time you'll be on this medicine, you'll be just fine. Well, Jake had his surgery, he filled the prescription, the pills ran out, heroin's cheap. A month and a half later, my son's dead. And I will tell you, my other children will say, we not only lost our brother, but we lost our mother. Because I am different. I will never, ever be the same. I think the first doctor probably did not have the education and he did not know. I think that they're educating doctors better. But yeah, I'm angry. At the end of the day, Jake did what he did, but we gave him his pain medicine. It's not like we gave a 16-year-old a bottle and said, here you go. His dad and I gave him his medicine, and like the doctor said, give him 2 perks every 4 hours. We did that. We did that for several months. He had to be homeschooled. We did not know that this could be a problem. Ask their family history, ask if addiction runs in the family. Jake's father and I don't have any alcohol or drug problems, but down in the history, great-grandfathers and things like that. So ask history, ask them, how bad is your pain? And maybe alternative medicines like Tylenol and Advil, or maybe let's do acupuncture, or let's try something maybe a little holistic, not just give you these pain meds and send you on their way. Even though they're saying they're prescribing only 7 days worth, if you do 7 days worth of medicine and taking 2 every 4 hours, that's still a lot of pain meds. It's way too many.
Probably about 10 years ago, there was a big push that we were under-treating pain. And we would get messages that pain is the 5th vital sign, and we need to make sure we treat it appropriately, and really appropriately at that time meant make sure we prescribed enough. And hard to say where the push for that came from, whether it was industry or just patients being in pain, but we recognize that what we do as orthopedic surgeons particularly is painful, so we prescribe narcotics. I think we first recognized within our group, the hospital a little while ago really wanted to take on opioid use head on. And it started actually under Dr. Meisenberg's direction, who leads our opioid task force. We recognized an opportunity to tighten things up, to try and become a little more scientific about our prescribing habits. And we embarked on an ambitious program to which has proved to be very effective, to standardize the use of narcotics. And basically we got consensus amongst the doctors that treated those procedures as to how many pills would be required for a given procedure. So if you take rotator cuff surgery, all the doctors that treat that agreed that we would prescribe 30 pills for that procedure. It can be easy to get everyone to agree to prescribe 30, but then to get them to do it, we needed to have an incentive, which is in the form of either a carrot or a stick, but we essentially tied part of their compensation, said you need to, when you do rotator cuff surgery, you need to prescribe the agreed upon amount. And if you do that, you'll get your compensation that's allocated to this part of our program. And if you don't, you won't receive that compensation. And this was pretty easy because everyone felt pretty strongly about it, and people have been on board with it. And it was logistically challenging because we had to embed it within our electronic health record so we could track it and report on it. But there's been universal support on it, and we've also created a feedback mechanism to make sure that that 30 pill count is the right amount. We realize what we do is painful, and if we don't want to get into a situation where we're undertreating patients. So every few months we track how many times we need to write a second prescription. And we have pill tracking diaries that the patients will fill out. And if we're not giving them enough, then we'll adjust that to 35, for instance, to make sure we're not undertreating our patients. The goal of the program was to prescribe the right amount for the right procedure, no more, no less. And we're finding that we're kind of hitting it. So when we look at our pill tracking diaries, our surveys from that the patients are bringing back with them on how many narcotics they've used, the amount that we're prescribing is pretty close to the amount that they're actually using. And in some cases, we can actually go down. And now every 3 months we look at the amount we're prescribing, and we adjust accordingly, so we can probably even prescribe a little less. But it's been very effective. And the biggest part of it really is probably eliminating the clinical variation, sort of doctors getting together and agreeing on how we're going to treat these things and recognizing the importance of it. There is opportunity to more responsibly prescribe opioids, and I do think a lot of that is low-hanging fruit, which is what you're seeing in the very good early results. I think that as this program becomes mature, we will not continue to drop opioid use, because if it works the way we want it to, we'll get to the exact number that people need. So we'll have an early drop, and as we change behavior and everyone's prescribing what we think is the right amount, it'll level off, and it may even have some fluctuations as we see what the patients really need for that given procedure. So I think there is a huge opportunity. Again, I think it's low-hanging fruit, but I do think that once you get people on board, it will probably level off.
Well, there's a new law that says that prescribers are going to have to check the prescription drug monitoring program whenever they start a new course of therapy with either an opioid or benzodiazepine. And then if they're going to continue that course of therapy, at least every 90 days they're going to have to check again. And additionally, pharmacists and dispensers are going to have to, on a daily basis, update the prescription drug monitoring program website. And so we'll have more up-to-date, timely information for prescribers to use to monitor and assess their patients while on opioid therapy. Well, the prescription drug monitoring program is something that the Department of Health at the state level developed in order to help providers to provide timely and adequate therapy utilizing opioids, while at the same time trying to avoid misuse. It allows providers to see if there are duplicate prescriptions, if there are medications that may interact with opioids and increase the risk of overdose. And so it really is a tool that helps providers to better manage their patients, and hopefully patients will have better outcomes. Well, at this time now, what we're finding is that people who are now utilizing street drugs started utilizing prescription medications. For example, in this country now, they're roughly finding that 75% of heroin users first started with prescription medications. And so even if it's not a historical thing, that the fact that we now have tools that can help us to avoid that situation is extremely important moving forward, and hopefully will decrease the epidemic moving forward and prevent it from ever happening again. And as a matter of fact, in 2016, Anne Arundel County providers rode at a rate that was 20% higher than the state overall. And so it really is incumbent upon the hospitals and providers to pay attention to that and to utilize the tools they have to try to monitor their own use of these medications to assist their patients, and also manage their patients' expectations in terms of pain management. Pain management doesn't necessarily mean pain-free. It allows you to function. And the whole point of the matter is that you as a provider and the patient have to come to some agreement about what your function and pain levels are going to be as you go through therapy. It's incumbent upon us to pay attention to that and to use the tools that we have, such as the opioid misuse prevention packet that we've developed for providers that allows providers to give their patients information about what to expect during pain therapy, what other options are available, and what you can do to dispose of the medication once you're done using it. We also have information in here that's for physicians, such as how to utilize the CDC's opioid guideline for prescribing medications, in addition to information about that prescription drug monitoring program here in the state and how you can get involved with that, particularly since now it is the law. In order to get copies of this, you can go to aaphysicians.org and click on the Stop Addiction sign.
The issue of opioid addiction or heroin addiction has become very personal to me because I've lived through it. My son was addicted, maybe is, but he's in long-term recovery now. He's been 6.5 years clean. I am grateful for every day that he is healthy, but I ache for other families going through this. Physicians are in a very unique place to help not just those with addiction, but the families as well. It's important for them when they're treating, let's say it's a pediatrician and they have an adolescent in front of them, it's important for them to recognize the signs of substance use or abuse, but also important for them to talk to the mom and the dad and the sister and the friends and find out, are you suffering too, and know where they can refer them for help. There is lots of help in this community, but I don't know that physicians are as informed as they could and should be to help families. During my son's journey, bad word, with this addiction, he did see a psychologist in the community, someone who was strongly recommended to me. At the time, I had to trust whoever referred this gentleman to me. And my son gave me permission to talk to the psychologist. He said, "Mom, if I let you go talk to him, will you get off my back?" I said, "Sure." I went to see the psychologist, and what he told me was, "I told your son to smoke less." And from that point on, I was very distrustful of the people treating my son.
Well, because it's affecting the citizens of our county and the community that we live in here in Glen Burnie, we noticed this problem starting back in around 2012 when I first started here at the hospital. And the problem wasn't getting any better. And I thought that we needed some action, so I collaborated with the Anne Arundel County Department of Health to put in place some grant-funded programs that would help alleviate the opioid epidemic. We've been trying very hard. We've seen over 1,000 patients in our ED that have suffered either an overdose or came in with an opiate use disorder, and we've gotten about 15% of them into treatment. And in my world, that's a pretty good number. We give out Narcan kits in our ED. They're supplied to us by the Department of Health. We do the overdose response training here at the hospital 3 times a month to help educate community members, and we really encourage people to use the drug naloxone. I think that we try to reach out to each department head, and we have 16 members on our committee, so each one of them actually has come and shown up. The people that do orthopedic surgeries and neurovascular surgeries, they understand that this is a problem because those are the patients that need the most amount of opioids. So they were more than willing to come to the table because we're all looking at alternatives to opioids like Tylenol and NSAIDs, which are things like Motrin or ibuprofen, other medications that are considered anti-anxiety medications, which have been shown to be very effective in pain relief, and they're much safer to use than opioids. We know that opiate addiction is a neurobiological disease, and it's very similar in terms of being a disease process as things like diabetes and hypertension. But what I always say to people that have that comment is, people with diabetes don't break into your house and steal your donuts. But people with addictions often do very negative behavior. So sometimes it's very difficult for people to empathize with them, but I don't feel like they're a lost cause because we know that until a person takes their last breath, there's always an opportunity for them to change.
Yeah, I became involved in the opioid crisis because I did have a coworker who was an opioid abuser and unfortunately did become a fatality in the county. So that kind of got me involved in wanting to make a difference and help stop this problem. Well, there are several opioid medications that we use commonly in veterinary medicine. Some of the same medications that we use in humans are also very effective pain control in animals. So a couple examples would be tramadol or codeine. Certainly for pets who have fractures or orthopedic surgeries or severe pain from certain types of cancers, they definitely need some stronger pain control than just a over-the-counter or a non-steroidal medication that would be, addressing their pain. And sometimes the dosages are different in animals as well because they metabolize drugs actually more quickly. So therefore the doses are actually higher that we prescribe for animals. So in some cases, we do have to prescribe a larger number or a higher dosage of the medication to treat a pet's pain. We do now check government-issued identification, so driver's license for anyone coming in that requests a pain medication for their pet. We also request that they do follow-up care, so we might go ahead and prescribe an initial 7-day course of pain medication to treat an acute injury or pain, but then we want to make sure that they come back for follow-up and that we don't just keep giving refills without seeing the pet. It's just been the last 5 or 10 years that we've really gotten good pain control for pets, because years ago we didn't prescribe post-operative pain medication for any surgeries. It just wasn't part of the curriculum for even learning. Unless they had an orthopedic injury or surgery, there weren't really pain meds sent home. But now we're knowing that pets do have pain and they do hide their pain more than people do. So that can be the first challenge, is determining, is the pet in pain, and if so, what is their level of pain? I can't ask my patients, what's your pain score, 1 to 10? I have to evaluate based on the exam findings. And sometimes too, when people bring pets in, their account of what happened doesn't match up with the physical exam, and that can be a red flag for either an abuse case or someone who is drug seeking. If you examine the pet and they're not limping or they don't have severe pain on their knee or their hip, but they're still requesting, opioid pain medications, that's the case where we would definitely say, nope, we're going to try non-steroidals first, or we're going to do some x-rays to make sure there's no fractures before we prescribe anything additional.
The heroin crisis has changed the way we approach medicine as educators. As we train next generations of medical doctors, pharmacists, dentists, and nurses, we have a real opportunity to stop addiction before it starts. The fact is, we know more about opioids than ever before. This crisis is pervasive and indiscriminate. We have all been touched by it, and we can all help stop it. Many people became addicted to medications such as oxycodone and OxyContin after receiving a legitimate prescription from their doctor. Put simply, we have to pay more attention. This will save lives. Step up and get educated on how to stop the cycle of addiction. You can find out more at aacounty.org/heroin.